All right, good afternoon. Welcome to Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine. Today is a non-COVID day, so we're doing a clinical problem-solving case, and through the year we will do about one of these every 6 weeks or so. They're generally quite wonderful and exciting and interesting, and I'll tell you more about it in a second. I also want to make a brief announcement. As I mentioned in an email to the department about a month ago, our plans are to retool Grand Rounds this year based on some of the things we've learned over the past year from COVID, and we've had remarkable interest with hundreds of people watching live, and now about 2.5 million people having watched them on YouTube. So we'll begin them live in person when we can, but for now we'll continue to keep them virtually. We're really trying to use new formats and shorter talks, really engaging speakers and new and cutting edge topics. So I hope you'll join us every Thursday. I put out a request for folks who might be interested in helping me plan them, and I'm thrilled to announce that Lakshmi Santosh, who's there she is, who's a faculty member in our pulmonary division and also in the Division of Hospital Medicine, former chief resident, master educator, now a new member of the Academy of Medical Educators, is going to join me to help plan these conferences as we go forward. So I think that's our best guarantee that they will be fantastic and well worth your time. So whether it's at noon on Thursday that you watch us live or afterwards, we're going to post them all on YouTube. I hope you do in the coming weeks. Next week, we'll be talking about clinical and policy implications of the new Alzheimer's drug with neurologist Gil Rabinovici and Rita Redberg from our department. Following weeks, Eddie Chang from neurosurgery talking about his really groundbreaking research on speech. We'll do a conversation with Ashish Jha on where we are with COVID. Sue Lynch will talk about the microbiome. I will interview Mark Larrett on the occasion of him retiring after 20-ish years running UCSF Health. So lots of cool stuff to come, and I hope you will join us. Well, as I said, we'll do a clinical problem solving about every 6 weeks. This one was prepared by Fangdi Sun, who is one of our stellar chief residents. And there she is. And she will come back at the end. And after we hear what the disorder is, we'll learn more about it from Fangdi. The speaker today is Rabih Geha. Rabih is assistant professor of medicine. He's based at the VA hospital. He attended Boston College for med school, Brown for residency, and came to UCSF, where he was a resident and chief resident, and honed his skills in medical diagnosis. It became his passion. And since joining the faculty 3 or 4 years ago, he splits his time between the ED and the wards, but has really become nationally known for his work in diagnostic reasoning, and probably most prominently is the co-founder of this remarkable set of tools, the clinical problem solvers, which is a multimodal effort to try to democratize diagnostic reasoning and help people do it better through a fantastic podcast, which you should listen to, as well as these amazing schema that help you think through how to diagnose different kinds of problems. It's a wonderful set of tools, and I'm grateful to Rabih, and talk about democratizing all of his colleagues, including residents and fellows and medical students and faculty who have worked on this, and it's become an essential resource all over the country. So thank you for being here, Rabih, and with that, we'll go ahead and get started. So I will present a case to Rabih, and the learning objectives are here to demonstrate the tenets of diagnostic reasoning by looking at an unknown case and to perform a cognitive autopsy to reflect on optimizing the diagnostic journey of a medical case. The ground rules are our discussant has not heard this diagnosis before, and we're very, very careful about that. The objective is to see how Rabih thinks through a challenging case. It is not to get the case right. We're not keeping score here about the journey, not the outcome. Rabih is known as the mathematician, I think I understand from your high school experience, but we're not keeping score. And we hope you are actively engaged in thinking through some of the problems. We have a couple of audience response questions for you. Feel free to put in questions into the Q&A box, and we'll try to get to them if we can. By the way, there is CME credit available for this, and if you're interested, please stay on after the end, and there'll be a website to go to and a barcode. And enjoy. This is really the fun part of medicine for those of us that think about patient safety. It's also the area that we often get wrong more than others, and so we need to continuously try to get better. And that is the goal here. So actually, before we start, Rabih, any comments about what does it feel like, the high wire act of starting one of this? What's the feeling in your stomach as you are about to embark on this with a lot of people watching you?
Well, one, it's hard not to thank you for inviting me here. It feels a little bit like coming home. It's not quite like being at Parnassus, but it's been a lot of time there at residency, so it's a delight to be here. Thank you. I also did want to really thank Fangdi for putting the slides together. And I know, having been in her shoes, that takes a lot of work. Of course, there's a lot of preparation to have the knowledge and reasoning tools required to try to show up here. But my only specific presentation for this specific was to figure out the timing of my haircut. Do I do it this morning? Do I do it a day prior? And I know Fangdi has spent probably hours doing this, so thank you so much. The feeling now, as I mentioned to you beforehand, a little bit like you kind of get more and more comfortable the more of these you do. And then I have to be honest, I feel more comfortable than I usually do because I'm scrolling through the participants list right now, and I see so many familiar names, people that I trained with, people that taught me, people that I had the privilege of training. So I'm feeling great and excited to jump in.
Good. Yes, you're among friends. So let's go ahead and get started. A 76-year-old man presents with 3 weeks of diarrhea. 4 to 5 watery stools per day with fecal urgency, no bright red blood or melena, mild diffuse abdominal pain. Symptoms started after eating at Burger King. Denies associated nausea or emesis. Endorses weakness, lightheadedness, and anorexia. He's intermittently felt subjectively warm. Denies dysuria or hematuria. Endorses multiple ground level falls without loss of consciousness, and most recently has not been able to get out of bed for about 3 days. Believes he's lost weight in the last few weeks and estimates that at 30 pounds of unintentional weight loss over the past decade. So we'd love all of you to stay and be engaged. So this is an audience response question. We'll replace this with the Zoom poll in a second. What are you most concerned about at this point? A toxin-mediated process, an invasive infection, an inflammatory or rheumatologic process, or a malignancy? And we'll give this about 10 or so seconds for you to think about it and then weigh in. This looks like the thing they throw up on the screen at the Giants game sometimes. Let's see. All right, I'll go ahead and end it there. And yep, there we are. So I'm not. Can you guys see the poll as well? You can see it. Great. So it looks like the winner is an inflammatory rheumatologic process with almost a tie between malignancy and toxin mediated, and then last but also fairly close, an invasive infection. So pretty broadly distributed answers. And let's go. So let me see if I can get rid of that. Let's turn to you, Rabih, and have you weigh in on what you think.
Ooh, I'm so glad I'm getting a little bit of input from the audience. It's very helpful. You know, I've been recently, this has nothing to do with this case, but I've been recently reflecting on why in medicine we always choose to start our presentations with a chief concern. And I bet there are many reasons, but one of them is knowing the relative amplitude of what is going on helps you prioritize your thinking. So if a story has diarrhea in it, has maybe some hypoperfusion issues that maybe has weight loss in it. The relative amplitudes of those three things really helps you filter the differential diagnosis. What do I mean by that here? I think when we first, if you watch and study your sheer level of concern for a case like this, it starts off with, oh, maybe there's 3 weeks of diarrhea, and then starts to ramp up with, oh, maybe there's hypovolemia associated with that diarrhea, and then later on you hear that there's been a tremendous amount of weight loss. And so if you just track your concern through this case, it is increasing. And I think the reason is, when most of us choose to study the diarrhea, it is usually the primary presentation of a case. To step back, most diarrhea is usually a little bit of quivering of the GI tract in the face of a systemic illness. And there's sometimes we blame very specific illnesses like Legionella having a propensity to do it, but the truth is a lot of patients come in with a little bit of diarrhea in the face of a systemic syndrome. And in the first slide, you're tempted to be like, well, wait, is the diarrhea the center of gravity of this case here? And there's reason to use that as a working hypothesis, but as the case moves on, you kind of move away from that a little bit. Why? 4 to 5 watery bowel movements is a fair amount of bowel movements. And that may be your spotlight, but as you start to hear that there's more systemic consequences of this, and I think there was a hint at that at slide 2 and slide 3 if we have those available. But then at the end of the day, you start to hear that the story involves a tremendous amount of weight loss, and that the time course is stretched from 3 weeks to a whole decade. So how do you begin to solve this problem? I think you begin to solve this problem by really keeping a very broad lens. So what are the active threads? I think the active threads are that this patient is having some diarrhea that appears to be prominent. The patient is having a tremendous amount of weight loss, and there appears to be either a cardiovascular component or a neurological component, as evidenced by the falls. So where are we in sum total? We're in a very nebulous territory. We're nebulous because the time course of the problem we're trying to solve is unclear. It could be 3 weeks, or it could be 10 years, or somewhere in the middle. We're nebulous because the story that we're trying to paint right now doesn't have a clear anchor. There's a lot of extraintestinal causes of diarrhea. The cardiovascular system may be on the hook, or the neurological system may be on the hook for these falls. And then weight loss over a decade is a very, very, very unusual and potentially very informative thing. So what would I be doing in real life? In real life, I'd be trying to understand the nature of this diarrhea. Is it inflammatory or not inflammatory as initial branch point? And I will say that at the end, we think of diarrhea as either osmotic, secretory, or inflammatory. And here the presence of the weight loss makes a secretory cause much less likely. A secretory cause of diarrhea is just like the kidneys having polyuria. There's no reason for weight loss. So I'm already thinking, is there a malabsorptive cause of diarrhea, or is there an inflammatory cause of diarrhea? But my true most profound diagnostic filter is 30 pounds of weight loss over a decade. That would prioritize a catabolic cause of weight loss. And what we mean by a catabolic cause of weight loss is essentially there's not enough calories coming in, be it because of food insecurity, because of dental issues, because of absorption issues, or most morbid of all, mesenteric ischemia. It usually is a catabolic issue if it's going to be something that stretches out so long. But there's a subset of inflammatory diseases that can cause weight loss at this tempo. Now, why would it be a subset? It's a subset because most inflammatory diseases play out their story over weeks, months, at most years. So what's a short list of devastating, slowly progressive inflammatory diseases? In the infection bucket, it really is almost exclusively Whipple's disease, a disease that is centered on a GI tract that takes forever to manifest. In terms of rheumatological conditions, most are much more hectic, but sarcoid and IgG4 disease can do it. And in the back of my mind, I'm trying to make sure that we don't miss a pseudo-inflammatory diseases, and the endocrinopathies have some inflammatory features to them. Could this be hyperthyroidism with feeling warm, diarrhea, and weight loss over 10 years? Maybe, but the other more sneaky one is to think about adrenal insufficiency. So there's the practical lens with if this patient's coming in because they have 3 weeks of diarrhea, let's focus on that. But there's the more
You're frozen on my screen. Can folks hear me? All right. Got it. So we're going to wait for a second. Hopefully he will show back up. Welcome to the world of Zoom and technology. All right, we're going to have a problem if he can't sign back in. Let's give it a second. Oh, lost him. There we go. Rabih, you're back. We lost you for a second.
It seems Zoom was allergic to my my rambling there, but I have returned.
All right, good. Yeah, why don't you finish up your thoughts? So or maybe I'll push you a little bit on a couple of things. So one thing you appear to have blown off is the Burger King. So you don't even mention it, and is that because even if we don't pay much attention to the decade, just the time course here of 3 weeks is too long for this to be food poisoning or an acute infection? Is that your reasoning there?
Absolutely. I think that's the tension here is what do you attribute the true time course? And there may be multiple diagnoses at play. Is this a patient who has a sinister cause of 10 years of weight loss, who has a superimposed toxin mediated process from Burger King? Very possible. But I've blown it off because it's a diagnosis of exclusion. The same reason in the ER I blow off dietary indiscretion or medication non-adherence as causes of decompensated heart failure. I can't prove those in the moment. At the end of the day, we might come back and be like, hey, you have adrenal insufficiency and you had a bad meal at Burger King. But the initial working hypothesis is probably not something that is hard to demonstrate definitively.
Okay. And the second thing you did was you added the possibility there's a cardiovascular or neuro thing here. And I think most of us mere mortals would have not blown it off, but packaged it as part of the diarrhea. Yeah. That, okay, he's got diarrhea, he's losing water, and he's syncopizing or lightheaded and no big. So why is it because that you're not willing to hang your hat on the diarrhea that you said, is there another clue here? And am I potentially getting faked out by the diarrhea and there's really something else going on? Or what caused you to go down that cognitive path?
Bob, I think our job is very hard because at the same time, we're trying to simplify the problem as much as possible by making assumptions, but also at the same time, making sure that we haven't locked in those assumptions. And for me, I can't tell you the number of times that I've had a patient who come in with diarrhea and then magically one day later it goes away. And so for me, I really have to watch diarrhea for a day or two to really prioritize it as the center of gravity of the case. And I think that if aliquot 2 and 3 continue to talk about diarrhea, its consequences like kidney injury and hypovolemia causing syncope or presyncope become much more probable. But right now, the only thing that I'm dropping my anchor in is weight loss, and everything else is nebulous. And so drawing definitive hypotheses like diarrhea causing presyncope on nebulous data leaves us a little bit more in quicksand than we'd want to be early on.
Yeah, and just to point out that one of the things that you're doing that's impressive is it would be logical and obvious to say chief complaints diarrhea is the story, and you're making the point that diarrhea is sometimes a partner of a more systemic illness and sometimes is just not that specific a finding. Sounds like part of what you're trying to do, sometimes the chief complaint gives you something that's super specific and you're going to run with that. It's just nothing else that does that. But this is one, when you hear diarrhea, probably also like when you hear syncope, right? It's one of those that could be almost 100 things and you're not going to anchor on it too much.
Absolutely. There's a whole slew of things like that, like headache, back pain, diarrhea. All those have too much of a diffuse localization for you to actually go to the organ that is associated with that chief concern. Okay.
And the weight loss, in some ways, the most striking thing is 30 or 40 pounds of unintentional weight loss over a decade. Are you going to do anything to try to confirm that? Or how when you hear that, do you sort of say, let me figure out if that's right?
Yeah. I think anytime that something is as extreme as this, like in your checklist, you want to make sure you want to verify it. And I think there are multiple ways to verify it. Of course, here at the VA, we have the privilege of the patients being weighed at every clinic visit that I have access to over a decade. So that's one way. And, there's many ways to look into the past. Just recently, I discussed a case of multiple sclerosis where you can look into the past with the MRI and see old lesions and new lesions show up on the same image. And the best way to look into a patient's past is through many pictures that they have. And at the VA system, we get to see their original picture. But looking at their driver's license is one helpful way. Looking at them and their, you may notice the suit is a little loose, and if their clothing is loose, that's another clue. So basically, find creative ways to look into the past, be it their picture, their EKG picture here at the VA, their clothing. And on exam, you may see evidence of that weight loss.
Yeah, no, I think that would be my first instinct here is to look at the driver's license. And the final point I want to make is so over the past decade, so what things does that rule out? If it truly is true, if it really is, this is a decade-long process. You sort of ticked off inflammatory and malignancy and infection. It sounds like the only infection was Whipple's, and that's sort of the only thing that could last that long, really. In the other categories, is there, like you said, mesenteric ischemia? Can you have mesenteric ischemia that causes weight loss over 10 years?
I think that this is the part that I think would be happening in real life is we're focusing on the medicine here, and I think a big dimension that I'm becoming more and more in tune to is the patient themselves. Do I expect the pathophysiology of chronic mesenteric ischemia to play out over this time? No. Is it plausible that social and personal factors limit a patient's interaction with the healthcare system such that they do this? Yeah, I think so. But I think if I say weight loss profound weight loss over 10 years, it's probably much more a deficiency in the calorie in problem, like psychiatric diseases, food insecurity, rather than the calorie being excessively consumed. I think that's the priority. And for me, the most morbid cause of calorie not getting in, the most acutely morbid cause, is chronic mesenteric ischemia, because it can have an acute component at any minute. And so that's why I pay special attention to that, because chronic weight loss prioritizes calorie not making it into the body, and the only hyperacute morbid possibility is a person with chronic mesenteric ischemia who's seeing me today for acute on chronic disease.
Right. So that's an interesting sort of point that there's one framing of this, that there is a chronic underlying illness that is now entering a acute phase, and it's one thing. There's a possibility that it's two different things. There's a possibility that treatment for thing one may be leading to thing two. Is that sort of how you're trying to pull all this together? Yeah.
I love a lot of this is storytelling, and a patient may come in handing us one book and trying to tell us, hey, this is my story. But it's not uncommon, especially if a story is playing out over 10 years, for them to walk in with 3 volumes of books and say, I have this condition, this condition, this condition. So I think at time 0, you have to be prepared to catch as many books as your patients bring.
Okay, let's go on. Great, thank you. There we go. Okay, aliquot 2. Past history, no medical care in 10 years, colon cancer status post partial colectomy. Past surgical history, distant inguinal hernia repair. No current meds or allergies, family history, sister with CLL and coronary disease. Social history, let me shrink my screen. Originally from the Pacific Northwest, San Francisco for 20 years, retired Stone Age programmer. I'd love to know what that means. Independent in ADLs and IADLs, no recent travel, sick contacts, or animal exposures, last sexually active 3 years ago, and health-related behaviors, no significant alcohol, tobacco, or drug use. Any comments you want to make about any of this?
No, I would say that the reflex comment is to focus on the history of malignancy. And I think that anytime that somebody has had cancer and has a weight loss in the foreground of their concern, that has to influence your analysis. The rest is really data that I would probably put to the side and re-examine once we clarify the foreground. Because as we talked about, the foreground is pretty nebulous. I'll say one thing about colon cancer: the vast majority of colon cancer recurrences occur in the first 5 years. And so here, if we truly believe that the clinical syndrome is decades old, actually, I misread that. I'm not sure. We don't know when the colon cancer is. So if it's recent, you might.
Well, it's hard to know, but no medical care in more than 10 years, and had a partial colectomy, which I assume is medical care. So let's assume it's more than 10 years ago.
I don't know why I'm called a mathematician. Clearly, I can't do numbers in front of you all, but
can't guarantee that that's right, but that's, I guess, the way I would interpret that. So the point you're making is, if the colon cancer was really 12 years ago, the possibility that this is a recurrence is really, really small?
Yes, I learned from my dear friend Sam Bronfield, who may be on here, that there are a couple of cancers to prioritize that can have an extensive period of possible recurrence, and breast cancer is one of them, especially hormone-positive breast cancer, and melanoma. Those are malignancies that can recur almost any time, but most other ones have a restricted window in which the risk profile is very high, and for colon cancer, I believe it's around 5 years.
And the partial colectomy, does that ring your bells at all in terms of some sort of structural issue or malabsorption issue or something else?
Absolutely. I think I think the colectomy here may, depending on how much colon was removed, you may be worried about fistula formation, stricture formation, gut absorptive time. So absolutely, I think basically now that we know that there's been cancer and surgery in the background, those are threads that we have to explore the current foreground with for sure.
Right.
But they may be, I should say, they may be solely influencing the presentation of an otherwise a syndrome that may not show up as diarrhea, may take the shape of that simply because of the patient's now bowel anatomy. So there's a caveat there with sure we might have to follow that thread, but it might be distracted.
Interesting. Okay, let's get to physical. 38.5, hypotensive, tachycardic, respiratory 22, 94% sat on room air, BMI 19. That's low. Thin elderly man, fatigued, alert and conversant, dry mucous membranes, tachycardic, irregular, no murmurs, clear lungs. This is gross. Sorry, I didn't do this. This is funny. Soft, non-tender, non-distended, no palpable hepatosplenomegaly, well-healed midline scar. Stool appears like melted fudge. I'm not sure I can go back to eating ice cream again.
I get a little bit of anorexia before this.
Yeah, really.
But yeah.
That's not good. Alert and oriented times 2, person in time, globally weak, can't sit up in bed, but difficulty lifting arms, sensation reflexes, and cranial nerves are normal. No edema, and skin, no rashes or ecchymoses. So yeah, let's stop there. And so what did you learn from the physical that you didn't know, and how does it change your thinking?
I'm proceeding with a lot of caution because a 10-year timeline does not marry well with an acute fever. Presumably, this patient hasn't had these vital signs for 10 years. So essentially, I'm in a space where I'm following the diarrhea, I'm following the falls complaint, and not assuming that it's related to the story that's happening in the background of 10 years of weight loss. And if you look at this you look at this, your immediate interpretation, as many astute clinicians and trainees on this call, is to say that this patient is infected and has sepsis physiology. Of course, a component of their hypotension is hypovolemic in nature, given the rest of the exam. So we know when somebody's when somebody's inflamed, we'll prioritize an infectious process, especially because there are hemodynamic consequences to it. And in terms of understanding where that infection may live, you have to marry that with the base rate, and the base rate will tell you to look in the lungs, in the urine, and the skin. But there's signal towards the heart. There's potentially atrial fibrillation, but that's not the only irregular rhythm. And there's signal towards the GI tract, and there's signal towards the neurological axis. I say that because we have the stool that appears that way, and of course the diarrhea. But I think there's a very, very astute exam pickup here. Whoever did this exam, I really, really, really commend you, because it's very easy to say that this patient has had so much. Has had weeks of symptoms, and maybe asthenic is globally weak, but you found some focality here. Not being able to lift your arms may be a clue that there's actually a neurological syndrome here. So where am I at? I'm focused on the acute dimension of this, and the acute dimension is there's hypotension with a fever that's infection until proven otherwise. And the threads that we have to clarify are the base rate. Base rate infection in a hospitalized patient is a respiratory tract infection in the middle of a pandemic, urinary tract infection, skin and soft tissue, hepatobiliary. That's the base rate. What are the clues in this specific patient? Why does this patient have a presumably new atrial fibrillation? What's the deal with the luminal GI tract? And what is this neurological syndrome? Those, I think, are threads that we can talk more about or reflect more about, but I'd be studying all those in parallel.
And would you be trying to tie this up into a bow, that there is some sort of febrile process that has a neurological aspect and a diarrhea-inducing aspect, or all might be separate threads, and this is a guy who's got some baseline thing and is now septic?
I think right now, the way I'm thinking about this case is like a lot of Zoom background. It's really, really fuzzy and not clear. And so there's nothing that I'm setting in stone, nothing. I'm operating with base rate, and I want to know what the x-ray is like, even though the lungs are clear. I want to know what the UA is. I want to know if there's liver enzyme perturbances to suggest a hepatobiliary infection. But there's no... all the borders here are very fuzzy and very murky and have to be very dynamic.
Yeah. I mean, one of the points I thought you made very well is if you think he's septic, you're sort of going with what's the base rate in the population, lungs first. And then is there a clue for belly? And
Mhm.
I'm struck by the dissonance between the melted fudge, I'm still trying to get over that, and the fact that his belly is benign otherwise.
Mhm. Yeah.
So where does that lead you to or away from the GI tract as being a thing?
Yeah, the this is the perfect example of how humbling medicine can be. The extremes of the belly exam. Belly complaint, normal belly exam may mean no problem in the belly. Belly complaint plus normal abdominal exam may mean acute mesenteric ischemia, pain out of proportion exam. So there's a luminal focus with the stool being discolored. And it's not uncommon that luminal disease processes, when they're restricted to the lumen and haven't caused profound ulceration or perforation, have a benign exam.
Mhm.
Is there something going on close to the peritoneum? Almost certainly not. Is there something going on in the luminal GI tract? I think with a history of colon cancer, colectomy, and stool that is discolored, I think you have to worry about that to some extent.
So would that be at least one unifying thing that this is mesenteric ischemia that has now led to sepsis from a leaky bowel?
I think that it's humbling how easy it is to not think about that hypothesis in this case when there's so many distracting features.
Mhm.
But if I put in the following pieces of the puzzle together, and I say you have an older adult who has a weight loss syndrome for 10 years, who presents with bowel symptomatology with diarrhea and melted fudge, who now has an acute superimposed infectious process, it's hard not to at least think about chronic mesenteric ischemia complicated by either bacteremia or an acute, maybe less sinister presentation of acute mesenteric ischemia. So yeah, that's definitely at play here.
Yeah. And is the sort of benignish exam in the facing, is that as Larry Tierney used to say, is that a pearl or a cultured pearl? That it actually is, the textbook says it, but in real life, these people have pain if they have significant mesenteric ischemia.
I almost certainly a pain is expected. How much your exam changes the pain, I think, is always a hard part for me. And I think the patients that I've seen, they have a lot of pain, but my exam doesn't necessarily reproduce that pain or accentuate it. So here, yes, the fact that he's not having pain probably reduces the probability of that. But have we seen a silent myocardial infarction? Yes. Can you see a silent GI infarction? Maybe less so, but I wouldn't rule it out because it's just way too morbid to use any single data point to rule it out.
Yeah. Okay, great. Let's go on. All right, we're gonna get some labs for you. And it sounds like you wanted sort of infection labs and as well as liver and a few other things. We'll probably end up with some nominal and chest imaging too. Okay, hemoglobin 10.4, platelets 48. Let me just see if any instinctive response to that piece of data. That's surprising.
I do. I hold my breath. Anytime I see thrombocytopenia, I do not breathe until I hear the following. Are there schistocytes? And is there heparin exposure? And so here, thrombocytopenia, presumably, you want to make sure there's no schistocytes, and you want to make sure that heparin isn't involved. And I think the combination of anemia and thrombocytopenia, they're priorities to make sure that there is no microangiopathic hemolytic disease process. So a more likely explanation is that the thrombocytopenia has resulted in acute GI blood loss, for example, causing anemia. But for me, this is what I teach. If you see this combination, hold your breath until you know schistocytes or heparin. And presumably there's no heparin here. So
in case we have med students on the line who I know hang on every word, like if it's going to take 10 minutes to find those things out, you will take a breath in between, right?
Yes, please do.
Okay. Here are the rest of the lights. CO2 low, BUN 73, creatinine 1.76, anti-gap 17 with an albumin of 2.6, lactate of 2.8. Anything strike you there?
I think this is none of this is all too surprising. I think that in the face of such a systemic illness, the kidneys at least will have acute tubular necrosis or hypovolemia involved in them. So no, this is all. There's basically in medicine we study data in two buckets. Is this cause or consequence? And it's very easy to say that the NI-GAP metabolic acidosis, hypoalbuminemia, lactate, and kidney injury at first glance before fluids are given are all consequence of what we have to figure out. So here I would not be dropping my anchor here. Here, this is probably all fluid and nutritional responsive features, and the underlying disease is more likely to be uncovered by incorporating the hematological perturbances that we have here. So no, these are all, I would say, just reinforce the notion this person is sick.
Yeah, I guess one of the things I want to point out as I listen to your diagnostic reasoning, which is fantastic, is that sometimes I tell students and residents, before you get the labs, go ahead and put your nickel down. What would you expect? And so retain the capacity to be surprised. Sounds like the platelets surprised you.
Yes,
The rest of this stuff doesn't at this point, right?
I think the only circumstances in which this patient has a normal or high hemoglobin really over this long of a syndrome is if they have a myeloproliferative disease process.
Right.
Anemia of chronic disease runs rampant, and this just proves that there's anemia of chronic disease and potentially an acute component with the kidney injury. The thrombocytopenia is unexpected and certainly is a feature of sepsis physiology, the thrombocytopenia of sepsis, but has a much more specific differential than all the other things which might wash away with tuning down the inflammation, anemia of chronic inflammation, and a little bit of fluid. So yes, what is the one helpful finding here? It's a platelets of 48, which again, the truth is you have to verify it because pseudothrombocytopenia, if this is just platelets clotted in the tube, you're back to square one.
Yeah. Okay. Let's see some more here. Let me shrink my screen again. All right. There are your LFTs and your INR, fibrinogen. What do you make of that?
So I take it that the AST is 124, the ALT is 59, the OCFOS is 220, and the T-billy is elevated. So now we're starting to gain a little bit of momentum in terms of—
looks like mostly indirect too.
And mostly indirect, yes. So the AST to ALT ratio, again, I keep going to the math, but the math is really helpful here. So the AST is much less specific to the liver than the ALT. The most common cause of an ALT to AST ratio, as you see here, greater than 2-to-1, is alcohol consumption. And here I don't remember that being a prominent part of the background data, but that's again when I would review that. But if your AST is higher, is double your ALT, and there's no prominent alcohol use, you have to step back and see, is there an extrahepatic source of AST? And historically, the AST is how we would diagnose acute myocardial infarctions, the AST elevation. But now we rely on a much better biomarker. More likely, extrahepatic sources are muscle cells and red blood cells. So when you see an anemia and a thrombocytopenia and an AST to ALT ratio elevated, you have to worry that red blood cells are the source of this AST. Now, why is that hypothesis gaining a little bit of momentum? Is you see the consequences of red blood cell destruction here in the form of indirect hyperbilirubinemia. So there's a pattern now that's emerging. There's anemia. There's an AST to ALT ratio greater than 2, which could be compatible with hemolysis, especially if alcohol use is excluded. And there's indirect hyperbilirubinemia. I would then glance to the LDH, which we don't have quite yet, but that would further support the idea that there's hemolysis going on. So we have a little bit of a picture here with that emerging, knowing that there's still the thread of a neurological dimension we were studying. And so could this be muscle leak of AST? So a CK would be very helpful. That, of course, doesn't explain the coagulopathy and the low fibrinogen, which are either nutrition or liver. Nutrition is certainly a possibility here, but that might pivot us back to saying, hey, is this actually all hepatic in origin because the INR and the PTT are elevated?
Okay, let's see a little more. Urine's pretty benign, stool's pending, chest x-ray clear, CT brain negative, CT abdomen pelvis, splenomegaly with multiple wedge-shaped hypodensities. And there they are. The arrows are very helpful in showing wedge-shaped hypodensities. Yeah. A very large spleen with wedge-shaped hypodensities. So I think we have an audience question here. So what additional testing would you prioritize? We have a TTE, more blood cultures, HIV, hepatitis serologies, peripheral smear. A lot of smear fans. All right, looks like this is looking like the recall here. So it looks like smear 72%, 15 or so percent for TTE, and not much support for any of the others. What do you think?
Fangdi, this is so incredibly written. You're telling such a wonderful story here and really making it a very wonderful discussion. Okay, I'll keep the first logical leap very brief. Wedge-shaped infarcts in the spleen equals occlusion. We've localized the problem now to a vascular problem. Now there's a caveat. A big spleen can auto-infarct itself, but usually not in the pattern of wedge shaped. So we now know that the problem is in the vessel. And I'm going to give you a very simple way of thinking about all vessel occlusion problems, especially on the arterial side. Pump, heart, atrial fibrillation, maybe irregular rhythm. Pump, pipes. Is this atherosclerosis? Is this vasospasm? Is this vasculitis? Pumps, pipes, plasma. What does plasma indicate? Plasma indicates an underlying hypercoagulable condition, like a malignancy, like microangiopathic hemolytic anemia, APLS, heparin-induced thrombocytopenia. Now, what is your insight? Whenever there's splenic infarct, the rate of a cardiac source of the splenic infarcts is very high. So we have to look at the pump. We looked at it electrocardiographic. Well, we looked at it with our stethoscope, but EKG causing the atrial fibrillation causing this is possible. Endocarditis and LV aneurysm, we have to look at the heart. We look at the heart with EKG and echo and blood cultures. Pipes, possibly, but there's no signal towards a pipes problem. Maybe we talked about mesenteric ischemia and vasculitis, but there's a profound clue to the plasma. Why? We studied the plasma. We've looked at it and we found that there's a problem in it. We found that the patient is thrombocytopenic. So there's a paradox that's set up here. The paradox is you're telling me the patient has a platelet count of 48, yet they're clotting. Thrombocytopenia plus thrombosis is a rare overlap. And that overlap prioritizes a microangiopathic process, the most common of which is DIC. So we're saying this patient has anemia, thrombocytopenia, coagulopathy, and thrombosis. They meet criteria for DIC. But that leads to another question: is what is the cause of DIC? But I think we have to look at this mirror because I was finishing the thrombosis and thrombocytopenia. The other two things we have to think about here is APLS, and APLS serologies would be very, very helpful. And then very rarely there's some infections that can do this, namely endocarditis. So we see infarcts, pumps, pipes, plasma. Pump on the hook for sure. We got an irregular rhythm. The patient has maybe loss of consciousness. In the pump, rhythm issues, LV aneurysm, but in a patient who's febrile, you have to worry about the itis. And the most common cardiac itis is endocarditis. And plasma, the priority is a microangiopathic hemolytic anemia, which may result from endocarditis, but also the possibility of DIC, which may be aligned with an infection. But you don't want to miss a catastrophic presentation of APLS, which doesn't fit all the features here, but certainly something to think about.
Okay. We're going to run a little short, so I'm going to move along here. The patient received intravenous fluids and broad spectrum antibiotics. Blood pressure got better. Hospital day 2, increasingly encephalopathic without focality. Developed AFib with rapid ventricular response. And now a few more labs. Procalcitonin is high. LDH 422 with normal haptoglobin and direct Coombs negative. Finally got our peripheral smear, large lymphs with irregular nuclei, thrombocytopenia without clumping, no schistocytes or spherocytes. Ferritin high. Blood cultures negative, stool cultures negative, HIV, hepatitis serologies negative. And this becomes your opportunity to tell us what you think this is all about.
Honest answer, I have no clue.
All right.
I don't think that you can make it. I don't think you can approach this confidently without knowing what the answer is. But if you wouldn't mind going back to the most recent slide, I think that's very informative. So we've proven that there's abnormal cells that are bursting here, and that we've proven that through the LDH. The hemolysis hypothesis is plus minus. The haptoglobin is normal. The most common cause, autoimmune hemolytic anemia, is negative. And we found a pretty marked abnormality, and that there's abnormal lymphocytes with irregular appearing nuclei, and that irregular appearance is usually signifies irregular activity. So I think it's very reasonable to pursue the hypothesis that these lymphocytes are the culprit, and these lymphocytes represent an abnormal population of lymphocytes and therefore represent some sort of liquid tumor like a lymphoma. The ferritin here is somewhat helpful. A ferritin elevation is typically in a space of a febrile syndrome with splenomegaly, cytopenias, evokes the possibility of HLH, but the specificity of that is low. And often the journey of HLH goes back to what is the infection, autoimmune disease. and cancer driving it.
Can you just give us what HLH is?
Oh, I'm so sorry. So HLH stands for hemophagocytic lymphohistiocytosis. And yes, I have practiced that many times.
That is fantastic.
But it's essentially, it's a kind of inflammation no different than eosinophilia or lymphocytosis. And it's a kind of inflammation that in the United States prioritizes cancer. So here, I think the case is building for a lymphoma based on the smear. And the question is, well, why would a lymphoma show up in this way through a microangiopathic process? And it might be that there is morantic endocarditis, which is cancer causing vegetations in the valve. And it might be that this is an intravascular lymphoma, a lymphoma of the blood vessels. But I think what would I be? Am I confident of what the answer is? No, but I am very confident that these large lymphocytes are markedly abnormal and deserve the spotlight. And the spotlight would be to study their malignant potential. And the explanation of the entire syndrome may come with their causing HLH, they are causing DIC, they are causing morantic endocarditis.
Great. And what would you do? What would you do?
I think an echo is important here. Flow cytometry would clarify the nature of these lesions. I think flow on the peripheral blood would be very, very informative. So would a bone marrow biopsy, but I think I'm not moving away from an echo to make sure that there is an proximal source to these lesions.
Okay. And all right, so diagnostic test returned. And so if it were not morantic or bacterial endocarditis, just from hypercoagulability or from an intravascular lymphoma, could you see those sort of wedge-shaped hits to the spleen, or do you think you have to invoke that it's clot somewhere?
I think like neurologists do all the time, the simplest explanation of clots in many places is a proximal source. But could you have a diffuse disease causing clots everywhere? Yes, I think so. But it's so much easier to say I have one thrombus here causing all this, but a backup explanation for sure is cancer causing a diffuse hypercoagulability. I think that's very plausible.
Okay, so your final answer is lymphoma, maybe intravascular lymphoma with HLH or something that's leading to hypercoagulability.
Yeah.
Yeah. All right.
As I started off with, there are many loose borders around this final answer.
Yeah. All right. Let's re-emphasize that getting the right answer is not important. Bone marrow biopsy, T-cell lymphoma, numerous macrophages with hemophagocytosis. Flow cytometry, which you asked for, peripheral flow, abnormal T-cell population with large size and expressing T-cell receptors, consistent with peripheral T-cell lymphoma. Let's go through the conclusion of the case and we'll learn more about this entity. Recurrent hypotension requiring pressors, dexamethasone per HLH protocol, weaned off, multiple platelet and cryo transfusions, worsening renal failure, refractory acidosis, plans for further treatment of lymphoma complicated by HLH, increasing respiratory distress. Patient wanted to be a DNR, DNI status, multiple conversations, elected to go for comfort care, and he passed away peacefully. And so the final diagnosis is peripheral T-cell lymphoma involving nodes, spleen, liver, marrow, and kidneys, and along with HLH. So not important that you got it right, but you did get it completely right. So nice when that happens too. So we'll hear from Fangdi in a second, and just go ahead, Rabih, reflect on it. And what was going on over 10 years? Is this? It's sort of hard to believe that that's what was going on, right?
Yeah, I know. I completely agree. I think it's hard for me. My knowledge is limited, but it's hard for me to. There are versions of lymphoma that are cutaneous, like Sézary syndrome, like mycosis fungoides, that can plague patients for many, many years. But I don't associate that with developing a peripheral T-cell lymphoma. So, is there a knowledge gap that I might have that explain a 10-year course? Possibly, but I just think this reinforces the idea that. Our jobs are impossibly hard. And I think getting better and better and better at diagnosis just means staying humble until you basically are given all these threads to follow. And in some instances, you have to follow all of them until you come up with a satisfactory explanation that explains the most important dimension. So the diarrhea may be unexplained here, the 10 weight loss, all the the weight loss over 10 years. So many patients have parts of their syndrome that are completely unexplained. And so my advice is you really cannot close in the door on any parts of a case until you've found a satisfactory enough explanation. I think having this is certainly, unfortunately for the patient and their family, accounts for the vast majority of things, but maybe not everything.
Yeah, great. Well, thank you. That was terrific. Let's bring Fangdi on to teach us a little bit about this entity.
Rabih, just phenomenal. So a little bit first about HLH. HLH in and of itself is considered a syndromic diagnosis. Broad strokes is a syndrome of excessive immune activation. The pathogenesis is thought to be as follows, starting with defective cytotoxic cell function, leading to uncontrolled macrophage activation, causing this sort of cytokine storm type of picture, which then leads to immune dysregulation and ultimately multifocal tissue damage. As we saw in this case, and as a syndromic diagnosis, it's really sort of a collection of signs and symptoms, which are listed here. If we can go to the next slide. This patient actually demonstrated multiple of these findings. In his case, the NK, or natural killer cell activity, actually was not checked. But even in the absence of that, clearly had enough criteria to at least strongly consider this diagnosis. I'll also point out here, and Rabih, in all fairness, we didn't share all of this data with you, but even without the pathology and without the soluble IL-2 receptor, which takes some time to come back, the patient actually had already clinched 5 of these diagnostic criteria, which led to, in part, some of the decision to do early initiation of steroids, as often happens in these cases. If we can move forward. Some key points is that HLH is really thought of as either a primary or a secondary process. Primary HLH is largely enriched in the pediatric population, in large part because it originates from genetic abnormalities of lymphocyte cytotoxicity. Whereas in the adult population, secondary HLH is thought to be largely acquired from certain triggers, as Rabih alluded to. Many of the most common triggers include viral infections, EBV in and of itself, but also through its connection with hematologic malignancies often comes up. Other infections certainly possible, malignancies, particularly hematologic malignancies, and then autoimmune disease, which we'll touch on in a second, particularly systemic juvenile idiopathic arthritis and lupus, and then finally immune deficiency syndromes. We always joke about HLH in the context of CPS cases, but the takeaway here is really that it is exceedingly rare, particularly in adults. The exact incidence is really not well known, particularly in secondary HLH, but most times it is not HLH at the end of the day. And then thinking further about the differential diagnosis, I want to touch on first this entity of macrophage activation syndrome, which really in and of itself is not a separate syndrome, but just HLH in the context of a rheumatologic disorder. As was mentioned, systemic infection and sepsis by and far tends to be the most common thing considered. And then some other things to consider in certain circumstances: liver failure with multi-organ complication, in certain hematologic conditions, cytokine release syndrome in the setting of CAR T cell therapy or allogeneic stem cell transplant, transfusion-associated GVHD, and then thinking more towards pediatrics, Kawasaki disease, and most recently in the COVID era, potentially MIS-C. And then finally, just a little bit on prognosis and treatment. So historically, HLH was unfortunately uniformly fatal, often due to this sort of picture of multi-organ failure. It is still, highly morbid, and as we saw in this patient, in certain cases can lead to rapid decline. We referenced here the HLH-94 protocol, which is often cited. It was the first treatment protocol developed by the Histiocyte Society as to a treatment protocol for HLH. And if you actually look back at that initial study, it was actually a study of about 250 children less than the age of 16, specifically without chronic disease. And so certainly you can imagine this enriched for primary HLH, although technically there were some secondary HLA cases in which there were new diagnoses of malignancies or new diagnoses of other conditions. The treatment protocol consists of dexamethasone, etoposide with or without cyclosporin, and intrathecal methotrexate. In the case of this patient, he actually only got to the dexamethasone and unfortunately decompensated before consideration of further treatment. And even with this protocol in this study, the survival rate was about 54% at a median follow-up of 6 years. There is an updated protocol you'll see at times. There's really limited data for this and so not often drawn towards. And then finally, particularly in adults with secondary HLH, really thinking about treating the underlying condition may actually spare you the need for this full sort of concordance of treatment.
Okay, thank you, Fangdi. Terrific. So, Rabih, let's give you the last word. And what are your final reflections and thoughts, having waded through this case?
Again, thank you for having me. It really is a delight to be here. And I think, whenever I reflect on these cases, I go to my origin story for wanting to do this. And it was actually outside my mentor's office in medical school as an MS3 reading an NAGM CPS. And that NAGM CPS, guess what the final diagnosis was? HLH.
Of course.
HLH.
But people sometimes say it's always HLH.
Yeah, I mean, the base rate is very high at a CPS case.
Right.
But I feel like for me, if I could talk to that person, I would tell them that the practice of medicine is the ultimate privilege. And this is, I think, a small fraction of what we do in medicine. Our jobs are very, very complicated, and we do a lot more than diagnosis. But I'd say I would tell them to power through the huge mountain that they're about to climb. And so for me, this is another great experience to have the privilege of thinking about medicine. And of course, like the privilege of taking care of a patient who got this sick. So thank you for having me. And for those of you who are listening to this and find joy in it as I did, power along and reach out to me anytime. I'm happy to be part of your journey.
Thank you. Thank you. So I think when you put this together before we knew that it would be an amazing discussion, but it seemed like a high probability, reasonable bet. So thank you for doing it. We'll give you a minute of free advertising for the Clinical Problem Solver. So what were you trying to do, and how's it working?
I hope it's going well. But we're trying to make diagnostic reasoning and medical education open and accessible to everybody, not just in terms of the resources being available, but actually encouraging everybody to elevate their voice. So if you're an MS1, not even in medicine, if you're an underrepresented minority in medicine, you are more than welcome in this space, and you are more than worthy. And this is a movement that brings all of us together to help our patients. And so we encourage you to join the movement.
And what is the movement? I know there's a podcast, and
Yes.
when you talk about sort of the different kinds of things you're doing, it's not
Yes.
just a podcast. So what are the core products?
Yes, so the podcast you can find on any major podcast player like iTunes and Spotify. We also host a daily virtual morning report. So that is also for free on Zoom every day, including today at 5 p.m. with Anna Frentz and Smitha, who are both here. They're hosting a Women in Diagnosis virtual morning report, which I will be there for. And we also do a lot of bonus stuff. We have an app. We have special episodes on Patreon featuring my co-founder Reza and I. And honestly, I can't do justice to the 1,000,001 things this team of 60 plus people is doing, but that's the stuff that is really available to me right now.
No, it's fantastic. It's really, really very, very cool. Okay, with that, thank you, Fangdi, for putting this together. Thank you, Rabih, for a fantastic and illuminating discussion. And thank you all for joining us today. If you're interested in CME credits, stay on. The barcode will come up in a second, as well as the website that you can look at. So here's a brief reference list. I'll leave it up for a second in case anybody wants to photograph it. Want to learn more about these disorders. And then we'll move on to the CME credit. Thank you all. And again, next week, we'll be talking about the controversy over the new Alzheimer's drug, which should be absolutely fascinating. And everyone stay well, and we'll talk to you next week.